Hello friends. So on countless requests, today I am going to deal with the extraocular muscles, their action and their orientation, and be very realistic about this video. I am going to tell you in detail what is actually happening and why it is actually happening. So let's start with our journey with the extraocular muscles. So first, if you start with the muscles of the orbit can be divided into two groups, the voluntary muscles and the involuntary muscles. The muscles which are working under our will, voluntary power, and those muscles whose actions are not under our control. Now, we are basically involved, more concerned with the voluntary muscles here, and these voluntary muscles consist of three groups, and these three groups are called as extraocular muscles. That is your four rectors, superior rectors, inferior rectors, medial rectors, lateral rectors, the two obliques, superior oblique and the inferior oblique, and one that is LPS muscle. And as I always say, LPS muscle is also a extraocular muscle. So don't get confused that we have got 6 extraocular muscles. No, you have got 7 pair of extraocular muscles. Alright. Now moving ahead with the involuntary muscles, which are lesser talked about because they are seldom required in the squint, but you should know their names. We have superior tarsal, we have inferior tarsal and the orbitalis muscle, right? Okay. Now if we are talking per se about the globe muscles, now those muscles which are inserting over the globe are basically involved in the ocular movements. So these are actually the 6 pair of muscles, the 4 rectus muscles and the 2 oblique muscles. So basically we are going to talk about the 6 muscles here, the 4 rectus and 2 obliques. So this is how we have converged our discussion mainly on these muscles, right? The superior rectors, the inferior rectors, the medial rectors, the lateral rectors, superior oblique and inferior oblique. Alright. Now first let's start with the origin of the muscles. So if I talk about the rectus muscles have a common origin. And what is that common origin? That common origin is this annulus of Zinn. What is this? This is called as the annulus of Zinn. And what is this annulus of Zinn? It is a tendinous ring. And this tendinous ring is present at the apex of the orbit. Orbit is pyramidal in shape. Now apex of the orbit, that is lying posteriorly, and the base is lying anteriorly, we already know. So the shape of the orbits are something like that, the medial walls are parallel to each other and the lateral walls are perpendicular to each other. So what was the relation between the medial wall and the lateral wall? It is something 45 degree, right? This is one medial wall and a lateral wall. Similarly, we have got another medial wall and a lateral wall here. So if you see, it goes something like this. These are the two lateral walls and in between we have got two medial walls, right? Now at the apex of the orbit, suppose this is your medial wall here and this is the lateral wall. So at this apex posteriorly we have got what you called as a tendinous ring called as annulus of Zinn. Annulus means round. So annulus of Zinn, which is giving origin to all the 4 rectus muscles. So their parent is same, lying at the apex of the orbit, and from there the muscles are coming and they are converging over the sclera. Superiorly, we have superior rectus. Inferiorly, we have inferior rectus. Medially, we have medial rectus, and laterally, you have lateral rectus. So, it is just like holding the eyeball anteriorly, basically coming from a small annulus of Zinn which is lying at the apex of the orbit. So, I think the origin of the extraocular muscles in the rectus muscles is very, very clear. Now, if you look at the insertion of these muscles, can you see this area? Now, this is called as the annulus of Zinn, which is lying at the apex of the orbit, okay, lying at the apex of the orbit, and then they are going and they are inserting over this eyeball. So, can you see, follow these muscles. Superiorly, we have got this superior rectus. Inferiorly, we have got this inferior rectus. Medially, medial rectus, and on that side parallelly you will have lateral rectus. Now, don't get confused with this muscle which is going through a pulley. This is your pulley because this is a oblique muscle which is passing through this pulley, trochlea. That is why the nerve supplying this muscle will be called as a trochlear nerve. So, that this one above is not the rectus muscle. The one, this one going through this pulley is not the rectus muscle. This is your oblique muscle, while this muscle which is coming straight, can you see and follow the path? This muscle which is coming straight and going superiorly here, this is your superior rectus, this is your medial rectus, and parallelly we will have the lateral rectus, and then you have inferiorly, this straight will be your inferior rectus. So, basically they are going and they are inserting at particular or fixed distances from the limbus. What is limbus? Limbus is the corneoscleral junction. What is limbus? Corneoscleral junction, and there are certain fixed distances at which these muscles will go and insert. So, it is not variable, it is fixed. So, what is the mnemonic there? We have MILS, M-I-L-N-S, medial rectus, inferior rectus, lateral rectus and superior rectus. So, start with 5.5 mm, 6.5 mm, 6.9 mm and 7.7 mm. Medial rectus, inferior rectus, then you have lateral rectus and superior rectus. So, if you remember, that is why the superior rectus holding forceps was having angle at a distance of 7.7 mm. So, now you know why rectus muscles are actually called as rectus, because they are the straight muscles coming from a common origin, inserting into the limbus corneoscleral junction at the fixed distances, and the mnemonic is MILS. The medial rectus, inferior rectus, lateral rectus and superior rectus. So, I think the life is simple up till now, not a problem, right? Okay. Now, a little twisting, the oblique muscles. So, oblique muscles, we have got only two muscles, superior oblique and inferior oblique. Now, if you see the superior oblique origin, it is arising from the body of the sphenoid. It is coming from the body of the sphenoid. So, this is not coming from the annulus of Zinn. Basically, it is the rectus muscles which take origin from a common tendinous ring called as annulus of Zinn. But sometimes they ask you a question that all of the extraocular muscles take origin from the annulus of Zinn except, and their answer you find to be inferior oblique, and one thing always pings in your mind, why it's not superior oblique also, because superior oblique is also taking the origin from the body of sphenoid, and answer is simple, that the superior oblique has two heads. So one head is coming from the body of the sphenoid, which is medial to the common tendinous ring, and the other head is actually merged with the superior rectus also. So that is the reason that it is considered partly coming from the annulus of Zinn also, while inferior oblique in no way is sharing its origin from the tendinous ring, and that is why the answer there is inferior oblique. Very clear? Now coming to its insertion. Now this is very interesting. If you know actually how they are taking origin, how they are going, and then they are inserting, you will actually feel the beauty of nature, how they have actually managed to make the eye having so many movements beautifully. Like we can elevate, we can depress, we can adduct, we can abduct, we can intort, we can extort, we can do conjugate movements, we can do disconjugate movements because of the specific origin and insertion of the different muscles. So if you see these superior oblique muscle, how it's inserting, it is passing through a pulley. This pulley is a fibrocartilaginous pulley, and when it is passing through it, right, when it is passing through this pulley, can you see, this is the pulley here. So when it is passing through pulley, it is tailor-made for the rotatory movements of the eye, like this. So basically it is coming from behind, like, and then here we have that trochlea through which it has to pass, and it is hooking around here, and then it is going and inserting again over the sclera. Now but when it is coming here and then it is hooking back and it is going like this, basically can you see we have got a oblique kind of action because the axis becomes very, very large. Now let me tell you the principles of axis. Actually when I say the rectus muscles are straight muscles, practically they are not straight. It is only this medial rectus and this lateral rectus which are just straight and they are inserted at 0 degree, right? But if I talk about the superior rectus and the inferior rectus, they are just at a very small angle, that is 23 degree. So suppose this is your optical axis, right? It's the passing through the center, optical axis. So basically the axis of the rectus muscle is not like this, it is at a very small angle, and that too laterally, and what is that angle? 23 degree. Now what is the significance of this? The significance is that when I start seeing laterally, okay, when I start seeing laterally, this optical axis also comes like this. Then the two axes becomes parallel, and therefore the maximum elevation and the depression that I am expecting from these rectus muscles will not be in the primary gaze. It will be in the abducted eye. So I think this is a very, very important point, because most of the times there is a confusion that the rectus muscles are actually the adductors, and that is a fact. Rectus are adductors. That is the tertiary action of the rectus muscles. The tertiary action of the rectus muscles is adduction, and the tertiary action of the oblique muscle is abduction. I am not talking about that. I am saying that the elevation and depression are maximum when the optical axis coincides with the axis of the muscle. So if this is my optical axis, the axis of the rectus muscles is laterally 23 degree. So when I abduct my eye, both will coincide and the rectus muscles will do maximum elevation and depression. On the other hand, if I talk about the obliques, they are at a very, very large angle. So if this is the optical axis like this, the oblique muscles are actually inserted like this. So they are inserted medially and at a very, very large angle. And what is this large angle? This is 51 degree. 51 degree medially. So now when the person adducts the eye, both the axes will coincide, and that is why maximum elevation and depression by the oblique muscles is done when the patient is adducting the eye. Are you getting this? So I am not saying about the tertiary actions. Now this is the most important thing. Whatever test I have taken till date, like we are performing daily tests on the Telegram channels, the common problem that you people all face, that I have grossly examined, is that you people tend to confuse in these two things. You people confuse that this is the tertiary action of rectus muscles and this is the tertiary action of oblique muscles. No, I am not talking about the tertiary actions. That RAD is for tertiary action. Rectus muscles will adduct, oblique muscles abduct. Not a problem, but that is a separate thing. I am saying that elevation and depression, this is done by rectus muscles also, this is done by oblique muscles also. So rectus muscle, whose axis is lateral, 23 degree lateral to the optical axis, will elevate or depress maximum in the abducted eye, while the oblique muscles who are inserted, who are at an angle of 51 degree and that too medially like this. So medial to the optical axis. So when we adduct, they will coincide and they will do maximum elevation and depression. I think if you got this point, if you understand this point, your life will become very, very simple, especially in understanding and solving the squint questions, because so many times you are just doing these small mistakes because of the problem in this concept. So if you accept and grasp this concept, most of the questions, even the Park 3-step test, when you are applying the second step and third step, okay, your life will become simple if you are grasping, especially in the step number 2. So what is happening when they are at a large angle? So if this is an optical axis and this is a large axis at which the oblique muscles are inserted medially 51 degree, what is happening? They are going and they are inserting like this backwards. So they are coming posterior to the equator in the sclera. While what was happening with the rectus muscles, they were coming anteriorly and they were inserting into the sclera straight. So they were inserted anterior to the equator. Now because they were inserted, the rectus muscles are inserted anterior to the equator, they were taking the eye in the same direction. R for rectus. Rectus means straight. S for straight and S for same. So rectus muscles will always take the eye in the same direction. That is another important principle. So if I am talking about the superior rectus, it will take the eye superiorly, inferior rectus inferiorly, medial rectus medially, and lateral rectus laterally. They will always take the eye in that particular direction, same direction. But when I am talking about the oblique muscles, which are there at a large axis, therefore their main action is the rotatory action, and they are forming the pulley and they are going backward like this. So it is coming behind, then it is hooking here and it is going back. So these muscles are inserting posterior to the equator. Because these muscles are inserted posterior to the equator, they are taking the eye in the opposite direction. O for oblique and O for opposite. So oblique muscles will take the eye in the opposite direction. Superior oblique will cause depression and inferior oblique will cause elevation. So I think now this is very, very clear. All right, very, very clear. They are tilted muscle at a very large angle, medial to the axis, they will do maximum elevation and depression in adducted eye. They will take the eye to opposite direction and they will do maximum elevation and depression in the adducted eye. Now, because these muscles are at such a large angle, their main action is not elevation depression like the rectus muscles. The rectus muscles were more or less straight muscles and therefore their main action was elevation and depression. I am not talking about medial rectus and lateral rectus. I am talking just about superior rectus, inferior rectus. And if you talk about the oblique muscles, the superior oblique and the inferior oblique, their main action is not elevation and depression, their main action is intorsion and extorsion. Now what is that? See, suppose this is your eye and I am seeing in the primary gaze like this. Now from this I can see inwards, this is like this. So this will be intorsion, rotating inwards. Or there is another condition where I can rotate the eye outward, that will be your extorsion. So there can be intorsion or there can be extorsion. So the primary action of the oblique muscles will be intorsion and extorsion, right? So yeah. Now, what are the basic differences between the rectus muscles and the oblique muscles? First, so what are the basic differences between the rectus muscles and the oblique muscles? Rectus were the straight muscles, these are the tilted muscles. Rectus muscles were at a very small degree, 23 degree. Oblique muscles are at a large degree, 51 degree. Rectus muscles were inserted laterally, while the oblique muscles are inserted obliquely towards the medial side. They are on the lateral side, these are on the medial side, and that is why the maximum elevation and depression is done by rectus muscles in abducted eye, while in the adducted eye it is the oblique muscles. Now another important thing about the medial rectus and the lateral rectus. The medial rectus and the lateral rectus muscles are just inserted in the horizontal plane. So these are the muscles which will not going to show the secondary actions and the tertiary actions. The reason being that they are having an angle of 0 degree. So if you have an angle of 0 degree, obviously you cannot expect these muscles to pull the eyeball in any other direction other than their own direction. So medial rectus just medially, lateral rectus just laterally, and therefore their actions are just adduction and abduction, nothing else. So when I am talking about the secondary actions and the tertiary actions, always remember I am not talking about the medial rectus and the lateral rectus. What I am talking about is the superior rectus, inferior rectus, superior oblique and inferior oblique. Now coming to the inferior oblique muscle. Now this is again a muscle which is not coming from the annulus of Zinn, the common tendinous ring, and I think this is one muscle that you have to remember peculiarly because it is practically the only muscle which is not taking the origin from the annulus of Zinn. This is actually coming from the floor of the orbit. If this is your orbit like this, so this is coming from the floor of the orbit, from the orbital surface of this maxilla, right? And where it is inserting, it is again inserting, making a oblique turn, and it is inserting in the posterior part of the eyeball behind the equator. Then why this is called as superior oblique and why this is called as inferior oblique? So both of them, that is superior oblique and the inferior oblique, are inserting into the sclera behind the equator in the posterolateral surface, posterior and lateral both. That is why their tertiary action Tertiary action was abduction because they are inserted on the posterolateral surface of the sclera because they are behind the equator, so in the opposite direction, but superior oblique on the supralateral surface and inferior oblique on the inferolateral surface. That is why one is superior oblique and one is inferior oblique. So this was about the origin and insertion. Now coming to the nerve supply, we have got so many cases of isolated nerve palsies in the squint. So that is why the nerve supply of the squint muscles become very, very important. All these muscles are skeletal muscles. All these muscles are skeletal muscles or striated muscles. Why I am emphasizing this? Whenever there is myasthenia gravis, where only the skeletal muscles are affected, there also we have a defect in the extraocular muscles because these are also skeletal muscles. So all supplied by third nerve except SO4 and LR6. So always remember SO4 superior oblique by fourth nerve, LR6 lateral rectus by sixth nerve, and rest by the third nerve. Now, what happens? Most of the muscles, that is extraocular muscles, are supplied by the oculomotor nerve, that is the third cranial nerve. Now, this third cranial nerve has got two branches. One is the superior branch and then second is your inferior branch, or I can say the upper division or the lower division. So now another MCQ is that which muscles are supplied by the superior division of the third nerve and which muscles are supplied by the inferior division of the third nerve. So how to get this? Always remember that there are only two muscles which are supplied by superior division or the upper division and which are on the superior side. So can you see these two? One is here, LPS muscle, levator palpebrae superioris, which is elevating this eyelid, and another is this, that is the superior rectus on the upper side. So we have got two muscles, one is the LPS muscle and second is your superior rectus muscle, which are supplied by the upper division and rest automatically by the inferior division. So now another MCQ is straightforward, which are supplied by inferior branch or inferior division and which muscle supplied by superior branch or upper division, you can easily solve. Now I am going to deal with the another milestone here, and that is your movements. See, you have got two kind of movements. Either I am talking about the uniocular movements or I am talking about the binocular movements in both the eyes. So uniocular movements and binocular movements, right? Now binocular movements will be divided into conjugate and disconjugate. First, if I talk about the uniocular movements, they are called as the duction movements. The uniocular movements are called as the ductions. Now these uniocular movements can be divided into three axes. We have got three axes in the eye in which the movements can take place. Like if you take the first one, the elevation and depression. So this is taking place through this transverse axis, Now suppose this is your eyeball. Okay, suppose this is your eyeball, something like this, okay, and we are talking about this axis, the transverse axis, right? So what will happen in this transverse axis, around if the movements have to take place around this transverse axis, either it will go up from this axis or it will go down. So basically the elevation and depression is taking place in this transverse axis. See, there are two things. One thing is called as axis and one thing is the plane. So in the axis, the movement take place around this axis, around this transverse axis, but movement take place in the plane. So it takes place around this transverse axis in the vertical plane, that is elevation and depression. Similarly, if I am talking about this vertical axis here, so when I am talking about this vertical axis, movement will take place around this vertical axis, but it will take place in the horizontal plane. Either it will be adduction or it will be abduction. Are you getting this? What is the difference between the axis and a plane? Are you getting this? Then third thing is, when I am talking about the rotatory movements. So suppose this is the eye here and I am talking about the rotation. So this is the 12 o'clock and this is your 6 o'clock, right? Now this eye can rotate something like this inward, or it can rotate something like this. So this is outward. Are you getting? If it is like this, so eye can rotate towards the nose, or the eye can rotate towards the ears. So if it is rotating medially, it is intorsion, and if it is rotating laterally, it is extorsion. Now sometimes people get confused between intorsion, extorsion and adduction, abduction. Now again listen, this is very, very important. See, adduction, abduction is in the horizontal, it is in the horizontal plane around vertical axis. If the eye is going medially, it is adduction. If it is going laterally, abduction. But intorsion and extorsion are taking place in antero-posterior axis. So eye is rotating inward or eye is rotating outward. So don't get confused. When I am talking about the uniocular movements in one eye, it can be in the around the transverse axis, it can be around the vertical axis, or it can be around the antero-posterior axis. Alright. See this. Now first we were talking about the transverse axis. Can you see? This is our transverse axis and the movements will be elevation and depression. Around this transverse axis, movements in vertical plane, elevation, depression. Similarly, if I talk about the vertical axis, so this is my vertical axis. In this vertical axis, now what is happening? In this vertical axis, the movement is taking place in the horizontal plane. So what is this movement? Adduction and the abduction. So when I am talking about the vertical axis, the movements are taking place in the horizontal plane, adduction and the abduction, while the third is your antero-posterior axis. Can you see now? So from the 12 o'clock position, either it is going to 3 o'clock position, or from 12 o'clock position it is going to 9 o'clock position. This is intorsion and extorsion. Alright. So let's see now the actions of the individual muscles. So though this diagram may be looking very complex to you, but if you follow certain steps, it will become very, very easy for you. First of all, remember that the rectus muscles will move straight in the same direction. Superior rectus will cause elevation, inferior rectus will cause depression, medial rectus will cause adduction, and the lateral rectus will cause abduction. So there should be no confusion, and the story of the medial rectus and the lateral rectus will end here because they do not have secondary action and tertiary action. Alright. Second important thing, the rectus muscles will do maximum elevation and depression in the abducted eye because they are inserted laterally 23-degree laterally to the optical axis. Similarly, the oblique muscles, they will be doing maximum elevation and depression in the adducting eye because they are inserted 51-degree medial to the optical axis. Second important thing, the main action or the primary action of the rectus muscle is elevation and depression, while the main action of the oblique muscle is the rotatory action. The reason being that they are inserted at such a high axis, that is degree 51, while the rectus muscles are inserted at a small degree 23 degree. So that means the main action of the oblique muscle is intorsion and extorsion, and the main action of the rectus muscle is elevation and depression. Now, which muscle will cause intorsion and which muscle will cause extorsion? Because rectus muscles, it's very clear because they are moving straight in the same direction. So, superior rectus elevation, inferior rectus depression. But how to decide about intorsion, extorsion? So, for that you have got a simple mnemonic SIN, S-I-N, SIN. SIN means superior intort. So, whenever I am talking about a superior muscle, it will intort, whether it is a superior rectus or a superior oblique, and this means the opposite. So, the inferiors will extort. So, whether it is an inferior oblique or inferior rectus, right? Now, what about the tertiary action? For the tertiary action, again it is very easy. It is RAD. R-A-D-D, RAD, rectus adduct. So, whenever we are talking about the rectus muscle, whether it is superior rectus, whether it is inferior rectus, the tertiary action is adduction. So, opposite is obliques abduct. So, whenever I am talking about the oblique muscles, whether it is a superior oblique, whether it is an inferior oblique, their action will be the abduction. And again, to remind you, I am not talking about the primary actions here. Here I am talking about tertiary actions, and the tertiary actions are concerned with the RAD. Recti will adduct. Now you will say, why it is not holding true for lateral rectus? I told you that medial rectus and the lateral rectus do not have secondary and tertiary actions, and therefore it will not hold good for these two muscles. So, opposite of this will be that the obliques will abduct. While if I am talking about elevation and depression, so maximum elevation and depression by the rectus muscles will take place in the abducted eye, and the maximum elevation and depression by the oblique muscles will take in adducted eye. So, when you combine these principles, it will become very easy for you to tell the action of any muscle. For example, suppose I ask you, what are the actions of superior oblique? So, what are the steps that you have to follow? First of all, see whether it's a rectus muscle or it's an oblique muscle. Now, here you are being asked about the oblique muscle. So, its primary action is not elevation and depression. Its primary action is intorsion, extorsion. Step number 2, whether it will intort or extort. So, for this you have SIN, superiors intort. So, now you have got that its primary action is the intorsion. Second thing, because the primary action was intorsion, extorsion, therefore the secondary action will be elevation, depression. Now, whether it will elevate or whether it will depress, for this you have that O for oblique and O for opposite. So, obliques will take the eye to the opposite direction because it is a superior oblique, therefore it will cause depression. So, you have got the intorsion, then you have got the depression, right? Then final step number 3. Step number 3 is the tertiary action, for which you have to follow the, what you have to follow? The RAD, the recti adduct and the obliques abduct. So because this is an oblique muscle, what will be its tertiary action? Its tertiary action will be the abduction. So here you are with all the three actions. Superior oblique causes intorsion, it causes depression, it causes abduction. Now if I ask you, this depression will be occurring maximum in which position? So now you should know that because it's an oblique muscle, so maximum depression will be caused in the adducted eye. Now once you know the movements or the actions of these extraocular muscles, it will become very easy to tell about the clinical testing positions. Suppose I want to test the medial rectus, just I ask the patient to look medially. If I want to test the lateral rectus, ask the patient to look laterally. That's simple. But what about superior and inferior rectus, superior oblique and inferior oblique? Now, how will you test them? The rectus muscles work best in the abducted eye. So, when the eye is abducted, now in the abducted eye, if you are asking the patient to elevate, then we are checking the superior rectus. In the abducted eye, if I am asking the patient to depress, this is inferior rectus. So, elevation in abduction is superior rectus, elevation, depression in abduction is inferior rectus. While the obliques work best in the medial position, adducted eye. So now eye is coming here like this. So obliques are here, and can you see inferior oblique is on the upper side and superior oblique is on the lower side. The reason is that the inferior oblique will elevate here. So what is done now? In the adducted eye, elevation will be done by inferior oblique, and in the adducted eye, depression will be done by superior oblique. The reason being that they are O for oblique and O for opposite. So here opposite will work. That means superior oblique will depress and inferior oblique will elevate. So I think now you are very clear which muscles are voluntary muscles, which are involuntary muscles, which are globe muscles, and what are the muscles that we are mainly concerned with the ocular motility, the origin and insertion of the rectus muscles, origin and insertion of the oblique muscles, what are their axes, what are their nerve supply, and finally what are their movements. Not only that, you should be also thorough what are their clinical testing positions, because you know, suppose I ask the patient to look down and then laterally, suppose like this, you are not following that first it should abduct and then elevate and depress. So what will happen? The person will first use the inferior rectus to see inferiorly and then looking out. Now he will use the lateral rectus. So here you are using two muscles, both inferior rectus and the lateral rectus. If you want to check just the inferior rectus, then you have to ask the patient to look laterally and then look down. So in abducted eye, only the inferior rectus will depress. So that is why the basic positions are already known in which the extraocular muscles should be tested. And because you know there are 6 positions, like we have got 9 positions of gaze. The primary position, the straight eyes, then we have got straight up, straight down, straight right and straight left, 4 secondary positions, and then we have got the 4 tertiary positions. What are tertiary position? Tertiary positions means when I am using the combinations right and up, dextro elevation, right and down, dextro depression, left and up, levo elevation, left and down, levo depression. So these are 4 tertiary positions. So total 9 positions of gaze. Out of these 9 positions of gaze, there are 6 positions in which I can check the working of all the extraocular muscles. What are they? The dextro version, the levo version, means 2 gazes, the right gaze and the left gaze, then dextro elevation, dextro depression, levo elevation and levo depression. Because when I am abducting, right, suppose I am doing the dextro version, So right gaze. So both the eyes are working. See what happens when I'm talking about the binocular movements. There are two kind of movements. One is your conjugate, another is disconjugate. Conjugate are version movements in which both the eyes will see in the same direction. So right gaze, the left gaze. Right gaze is dextroversion. If I am doing a binocular movement, a conjugate movement and looking towards right, I will have to use my both eyes. So right eye is also seeing towards right, left eye is also seeing towards right. So which muscle of this eye? Lateral rectus of right eye. Which muscle of left eye? Medial rectus. So both are contracting simultaneously. So basically both the muscles are used. In this it is abducting. So lateral rectus. Here it is adducting. So medial rectus. So in these 6 positions, the dextroversion, the dextroelevation, dextrodepression, levoversion, levoelevation and levodepression, you can check the actions of all the extraocular muscles, and that is why out of the 9 positions of gaze, these 6 positions are considered to be the cardinal positions, and the muscles which are used in these positions are called as yoke muscles. While I am doing the dextroversion, it is the right lateral rectus and the left medial rectus which are the yoke muscles. While I am doing the levoversion, it is the left lateral rectus and the right medial rectus which are the yoke muscles. Similarly, if I am talking about the dextroelevation, so if I am doing the dextroelevation, what is happening? Right eye is abducting and elevating, left eye is adducting and elevating. So elevation here in abduction, so right superior rectus, elevation in this eye in adduction, so left inferior oblique. So this is how you are going to get the pair of yoke muscles. Sometimes we get a hookup and not able to decide what are the yoke muscles. So for that, a simple tip, just flip the muscle. Suppose they ask you what is the yoke muscle of right superior rectus. Flip the muscle, left inferior oblique. So that is a very quick way of getting the yoke muscle, but that does not mean entirely that you should follow this and you should not know the concept behind it. Obviously knowing the concept is very, very important, but this is a quick way of recalling after you know the concept. So by this we have come up to end of the video. I hope this video will help you like anything. So many of your problems, your silly mistakes, dilemmas must have come to the end by the end of this video. So I hope that you will definitely be getting maximum benefit from this video. Do write to me, how do you like the video, what are the other topics you like me to make the video on, and definitely your feedback, your suggestions means a lot to us, and these are like just like boosters for the faculties. Keep us motivating to work 24/7 to help you. Thank you and happy ophthalmology.